Hey, it's Ben from Atma TV here with Dr. Reed Smith, who's just come off stage at ATMC 19. Hey, Reed, how was that? That was awesome.
Thank you very much. Yeah, I'm sweaty. I'm running around up there going crazy. So it was great. Great talk, great group. Good to see you.
It's good to see you, mate. Thank you so much for coming out and joining us. There was a very electric atmosphere in there. How'd you find it?
It's great. I mean, I wish we had more events like this in America. We've got a couple, but you guys have put together just one of the most professional, best groups. As I said to the people yesterday when I got in, this was the most organized conference that I've ever been a part of speaking at, and I've spoke all over the world. So you guys have really nailed it, knocked it out of the park.
Oh, thank you so much. The Atma crew has done a great job. Maybe we'll have to set up Atma America tour.
Yeah,
we could talk about that offline. That's it. We're coming to you, USA. So what about, could you just give us a quick bluff about what your talk was about for all the people that couldn't make it today?
Sure. What the question that we kind of posed in our research was how do we improve survival in active shooter events? We understand that military data, so military combat data on what kills people in combat and how they can survive is a bit different. The application is different for civilians. So we did a series of autopsy studies that looked at people who'd been killed in active shooter and defined the most common causes of death, those that were potentially preventable. If we had done something, potentially we could have saved their lives. And what we found is that it's much different than combat. In combat, where external hemorrhage control, tourniquets, compressible bleeding is the kind of primacy of what can keep people alive. In active shooter, it's actually not. There are people who bleed to death in active shooter, but what we see much more is torso and kind of chest and abdominal injuries. In active shooter, those are the ones that the people die from that potentially we can do something for. So as opposed to bleeding first, then respirations, according to the March algorithm, we're thinking that maybe we should go to the chest first because that's probably going to be our most common injury that's going to kill people quickly. We do see people with extremity injuries in active shooter, obviously, but the vast majority of them are soft tissue only. They're not involving the vasculature. And let me clarify what I'm saying, because I'm not saying that we should not use tourniquets or we don't need tourniquets or we shouldn't focus on bleeding. That is not true at all. It's just that it's just that bleeding control and tourniquets are not the only thing we should focus on. Yeah. We have a tendency in America to say, oh, the tourniquet's going to save everyone's life. We don't need to do anything else. That's just not true. What we need is tourniquets and then chest injuries and then keep you warm and then don't fill you full of salt water and all these things. So it's just the bleeding control is important. It's the first step, but it is not the only step that we need. If we really want to save people, if we really want to move the needle towards survival, it involves all of the things, not just bleeding control.
Awesome. So you're talking about getting away from focusing on like a treatment adjunct and looking at a treatment process, like treating the whole casualty.
Yes, treating the whole casualty. It's the quick, what we say is rapid stabilization of the immediate life threat, which may be a brachial artery bleed. It may be a chest injury that's compromising your ability to breathe. It may be, a couple gut shots and you're getting hypothermic. Yep. So we have to address all of those things to keep them alive long enough to get to the trauma center where the surgeons can then fix them. Awesome. So it's the system of care. It's not focusing. Americans, we love to focus on one thing. Yep. Right? And we shouldn't stop focusing on bleeding control. We must continue that, but we have to build upon it. It's the first step. It's not the only step.
That's exciting, and it's wicked to look at a different point of view, to look at the whole process of treating a casualty. Yeah. And guys and girls at home, if you didn't get to see this, it'll be on the podcast on the Atma website. So please jump in, have a listen to Reed's amazing talk. So getting from that, what's the next thing inside? So you did an amazing talk just then. What's the next thing you're looking forward to most about ATMC 2019?
I'm looking forward to hearing. You have some amazing speakers. So I'm looking forward to hearing those speakers talk and then just hearing how you guys do things and seeing the differences. And it's interesting because as much as we're different, we're the same. Yes. And so it's very, you have some things in your system that make me jealous that we can't do in America, and so it's interesting. And I've already, yesterday, with some of the stuff we did yesterday, I took some notes back and there's stuff I'm taking back that I learned. And so I really feel like I can learn from what you guys are doing, in this country, and that collaboration. And that's what I love, is the collaboration. And, what you guys done in 2 years is amazing. But now you guys are starting to truly contribute to the kind of international tactical medicine, group. So that's wonderful.
It's really interesting you say that, because a lot of Australians will be like, oh, I want want to get over to the US and learn a lot. But it's so good that we're collaborating, and it's really people saving people, isn't it?
Absolutely. And I mean, it's not, no one is better. Everyone has to apply this knowledge according to their population. And that's one of the problems we've seen with kind of the pure military guidance, TCCC. TCCC is written for the military population, military combat, military laws. That's different than if I walk outside this hotel in downtown Brisbane.
Yes.
Right? That's a different population. So, but that doesn't mean they're wrong and we're right, or we're right, we're wrong. It just means that you must take this information and apply it to your population. So I would say to the Australians that want to come to America, come on over, right? Our McDonald's are better than yours, right? You're going to learn stuff in America on the American population. You then bring it back and have to apply it to the Australian population.
Yep.
I'm doing that now. I'm learning what we're doing for the Australian population. I can then apply that to the American population. Just a bit different.
It's exciting, and we're all collaborating. Yeah. Fantastic. And there you heard it, team. We'll all head over to SOMES of 2020 in Rayleigh.
Exactly.
So what about tactical medicine? What does tactical medicine mean to Dr. Reed Smith?
Well, so when I first started looking at tactical medicine, I was a combat medic in the First Gulf War, so I was embedded with the Marines. I never deployed, but I learned a lot about about the combat operations and what we do, and that's what I thought initially tactical medicine was. It was a military thing, but then you kind of start to understand the similarity between kind of military special operations and law enforcement special operations, and so that's that to me was the initial what tactical medicine is. I think tactical medicine, this term tactical, is one of the things that's holding us back because. Tactical, when I hear tactical medicine, I think, or at least most Americans think of SWAT guys.
Yeah.
So I have plenty of police officers, I have plenty of firefighters, plenty of EMS personnel who say, well, I don't do tactical medicine, I'm not a SWAT guy. But the truth is, we make tactical decisions on every call. Every house fire has tactical decisions. Every car, every road traffic accident that you guys come on, you make tactical decisions. Where do I park? How do I position my vehicle? What are my other risks? Those are operational tactical decisions.
Yes,
and so
yes.
Tactical medicine in its inception was around SWAT. It was around military and civilian special operations. I think that it's grown beyond that.
Yep.
And I think what tactical medicine means to me is actually operational medicine. It's medicine that adapts for the operations and helps to mitigate the risk to providers and benefit the patients in a way. So it's not limited to law enforcement. It's not limited to terror. It's limited to any dangerous operations that we have, and how do you mitigate the risks and maximize the benefits?
Yes.
And that can happen in a lot of different ways. So it's not just SWAT. It's just SWAT.
And I love that you say that, because here in Australia we get a lot of people say that too, whether it's be just not understanding or not knowing, but people saying, hey, I don't need to do tactical medicine, I don't need to know it, but it's a decision-making process to look after the provider and the casualty and the bystanders, isn't it?
Exactly.
That's awesome. So you heard that straight from Dr. Reed Smith. What do you think the biggest issue is in the continuum for the tactical casualty?
I think that right now it's getting penetration into getting people to understand that. We still, certainly in America, we struggle with people who feel that they don't have a role here. They aren't going to go get kids out of a school that have been shot, or they feel like the police can do that, or it's that lack of collaboration, or what we call silos. So I think that the silos in America, they're starting to break down, but that's a process. It's a cultural process that takes time. I'm sure it'll happen here too. Is that cultural inertia, especially among first responders, is very hard to overcome. That to me is the biggest obstacle for us to overcome in tactical operational medicine, is breaking those silos down and understanding that we must work together, as one team to kind of with the same overarching goal of saving the patient, kind of stopping the killing and stopping the dying.
Yes, yeah, very much that cultural shift, or that change of information overpowering potentially an opinion, or like just not understanding.
Exactly.
That's fantastic. Okay, so last thing, just a bit of a quiz, just to try and get to know you. All right, soft TW or CAT?
Neither.
Neither? Oh, which one?
Yeah. I'm a big fan of the military emergency tourniquet, which is a special operations tourniquet that came out of the Navy special operations community. It's an open loop, unlimited uptake tourniquet.
Wow.
It's a little harder to learn to use, but it's much more forgiving.
Yep.
And then we also are big fans of the SAM XT for our citizens.
Yeah.
I mean, the CAT it's the ubiquitous tourniquet. It certainly has saved thousands of lives. I think soft T. If I have to choose between the two, I kind of like the soft T.
No, I like your conversation. We're opening it up. There you go. Like, start researching products, team.
Well, and the big thing is that COTC has come back and said what we've always always said from a C-Tech perspective is tourniquets are like pickup trucks, right?
Yeah.
Maybe you drive a Ford, maybe you drive a Chevy, maybe you drive a Toyota. At the end of the day, they all carry, manure in the bed. They all kind of do their job.
Yeah.
And so tourniquets are the same way. As a whole, the mechanical tourniquets, they all work and they all fail.
Yep.
And we get asked that question all the time. I get asked, what's the best tourniquet? Here's the answer.
The one you got?
The one you got.
Yes.
What's the one you got? The one you know how to use.
Yeah.
You know its strengths and its weaknesses.
Yeah.
And and there's people and there's lots of tourniquets are a funny topic. I'm getting off topic here, but tourniquets are it's like religion.
Yeah.
If I get a cat guy and a soft T guy in the room together, it's like putting a Palestinian and an Israeli in the room together. It's religion. But at the end of the day, they all work, they all fail.
Yes.
Which tourniquet do I want? The one that's immediately accessible that I know how to use.
Yes, awesome. Okay. CT6 or Slishman traction splint?
I don't know, either one.
Either one?
Yeah.
Both good? Yeah.
Yeah, sure.
Okay.
Yeah.
Good. All right. Quick clot or C-locks?
So I'm a big fan of the C-locks is a based on the mechanism of action. It's a chitosan based gauze. Quick clot is great. It's kaolin based. It's an inert mineral. If you look at the mechanism of action on how they work, kaolin works. It accentuates the clotting cascade.
Yep.
C-locks, the chitosan based causes, they work external to the cascade, which means that if I'm a citizen who takes Coumadin, warfarin, I'm on blood thinners, and my clotting cascade is altered, right? Then, although there's not been a lot of studies on this, but just if you think about it, I would prefer to have one that doesn't require a clotting cascade. So I think for elderly citizens, I much prefer chitosan.
Yep.
For young, healthy military population, quick clot's fine.
Yep.
Again, at the end of the day, what's interesting about the studies of quick clot and C-locks, and they don't like it when I say this, they only are slightly better than just plain gauze.
Yeah.
So really what it is it's just the same thing. What do you know how to use it? And if all I have is a dirty sock, I'm shoving it into your leg wound. I'm putting pressure on it and doing the same thing. So we use C-locks because of the we have a pretty hefty elderly population. We have a lot of people on blood thinners. We use it because it works out. But again, pickup trucks, right?
Awesome. I like it. I love this. This is awesome. Beer or wine?
Oh, totally beer.
Taxi or Uber?
So I'm an old school guy, so it drives my wife crazy, but I like taxis.
Yeah, okay, cool. Roger.
I'm always worried this guy shows up in a car. I'm like, I don't know who you are. You're just
Are you tracking me? What
yeah,
am I doing?
he's got like mints and a bottle of water in the back. Like, what are you putting in this? You gonna wake up somewhere?
Yeah.
With my
Do you want
pants
a
off?
drink? I'm not sure. Yeah, where am I going?
Yeah.
iPhone or Android?
Oh, iPhone, totally.
iPhone,
yeah.
good. All right. Cardio or weights?
I like high intensity intervals.
Yeah, training.
Yeah.
Roger.
So but I'm old, so I literally got off the plane yesterday morning, got in at 6 a.m. The hotel's like, get the hell out of here, you can't check in. So I went and changed clothes and I went for a beautiful run, down
along the river.
Yeah, and what did I do? Right when I crossed the ridge, went down, I pulled my muscle. I pulled a calf muscle, and I'm like, because I just turned 50. Like the wheels are falling off, man.
50, the 50 and there's some good
That's not what my wife says.
Well, thank you so much for your time, Dr.
Yeah,
Smith.
thank you guys for the opportunity.
Appreciate it.
Yeah.
And
awesome.
wait out for the next episode. Have a great day at home. See you soon.